So we are here in a very interesting conference, and I met Dr. Verma, and he's doing very interesting work on occlusion. And I personally believe that success of implants is completely on occlusion, because it's just 3 months of healing for an implant into the bony site and tens of years into the mouth with prosthetics. So first of all, let's meet Dr. Verma. Sir, could you tell about yourself?
Hi, I am Dr. Shalan Verma, and I am the head of dental department of Fakir University Hospital based in Dubai. Been practicing over 23 years now, and I've come to attend this wonderful conference.
Yeah, it's very interesting because see, even I personally believe this is my 17th year of practice. So, occlusion plays an exceptional role in implant prosthetics, and bruxism is a very underrated, very understood, and something that everybody has not mastered as yet, which you are actually working towards that. So, if you could give your insights on bruxism. First of all, what is bruxism?
Basically, bruxism is in simple terms, we would say it's a grinding of the teeth. And now it was previously controversial. Now it is coming to more of a centrally generated pattern rather than peripheral.
So basically, if you understand, I'm getting too much sensitive teeth, that could be bruxism because your teeth are abraded. So we normally use X-rays, the bite patterns, the occlusal patterns to identify if the patient has bruxism, T scans, etc. Do you have anything different than this to diagnose bruxism?
Well, I showed in my presentation there is no standard way, but if you're looking at least some kind of credible standard diagnosis, then it can be polysomnography, which is basically the sleep studies which can be done to identify bruxism. But there are a lot of other things like clinical signs, and the patient also gives the history, and we can ask the spouse of the patient. So generally it's either patient oriented or our clinical signs.
So if you're looking at the, say, asking wife, so what are the right questions to ask? Like what are you listening for? Say, because our complete people who are listening to us are dentists. So what is the diagnostic ear understanding that, okay, I'm going to see this, I'm hearing a noise, etc.?
Yeah, of course. See, most of the times, even before asking, the patients would tell you that, my spouse, grinds the teeth at night and there is a noise. But more important than this is you have to make the patient aware. I discussed about a case wherein I mentioned that the patient was not ready to believe, and you mentioned to them that you're grinding your teeth, and they are taken aback. They think that something is not right.
Right.
It is not the case. You have to convince them that this is may not be pathologic, but maybe a physiologic phenomena which might be happening. So you need to observe yourself, especially in the stressful situations. And I mentioned that particular case who told me that during watching a stressful serial, she actually noticed that she was grinding her tooth. So you need to reinforce that thought and make the patient believe that this might be possible and there is nothing wrong.
So basically asking a good case history, understanding from the spouse, partner. If there is no partner, then any other test that you do to identify bruxism?
We see a lot of clinical signs.
Right.
And of course, as I told you, the gold standard is polysomnography. But yes, you mentioned one point about the systemic history. We need to be very thorough in the history, because in the history you will find a lot of points, because bruxism is also secondary to so many things, like for example, patients are taking medicines for depression, SSNRIs, or like it has been associated with sleep apnea.
Correct.
And other neurological disorders, restless sleep, and gastrointestinal disorders, acid reflux. So it has a very close correlation.
So there's a very interesting question that is coming to my mind. So if a patient has been bruxo for all his life and he didn't know, and he lost his teeth maybe because the teeth were grinded away and the doctor extracted it because they were unrestorable. I'm talking about, say, years back in their life. And now these patients have come to our dental practices for getting a dental implant. What are the considerations that you would keep in mind if the patient is a bruxer? Like, common findings like, chipping of the teeth, or, if it's a ceramic or hybrid dentures can break. So what is it that you keep in mind to treat such cases?
Yeah, so if we look at the literature, literature sees no contraindication apparently, but yes, it can lead to mechanical complications, but not the biological complications. That is the fracture. So in such cases, let's say if it's a multiple implant case, we should not look at any cantilevers, the number of the implants, the type of the implants, and splinting, and the later on a protective splint should be placed to protect the dental work. That's the basic idea.
So you mentioned about splints. Now tell me, what do you prefer? There's a very big split in dental industry between hard and the soft splint, especially in implant cases. What is the kind of splint that you prefer?
See, actually, it's a very controversial thing. But let's say this has answer in two parts. One is that when we take a history and you identify the patient has obstructive sleep apnea, in that case, it's preferable not to give a maxillary splint because it can already increase the obstruction and the posterior pharyngeal space is compromised. Now, in such kind of cases, a mandibular splint is preferred. A very simple phenomena, if you have some kind of TMD issues associated with it, a hard splint, and if not, a soft one. So this is just, I'm giving a very brief idea about it, but as an orthodontist, I would like to ask you as well that in my cases, not that I am against any orthodontist, in my cases, I have seen when we take the history, there are a lot of cases, wherein the bruxers or the patients with bruxism have done their orthodontic treatment.
Correct.
So what is your take on that?
So agree and disagree, because what I have seen personally in the practice is many a times a deepening of the bite that happens because of orthodontics. So if you do not understand the vertical patterns correctly and you do not treat to the vertical patterns, I personally believe that there are chances that you can create excessive pressures from the bite, which can over a period of time lead to bruxism. So yes, I'm not denying the fact, but it's not the only factor that would be there, because there would be chances that the patient has a deep bite or a bruxism problem before they started orthodontics,
Yes.
and it just worsened. But in my practice, what I have seen is that I have seen some cases where reduction of excessive bites also. So I think understanding the vertical pattern and giving the correct verticals, how you give a JR in a edentulous case, if you finish at a very good verticals, then I think these problems will not arise.
You are, let's say when you're finishing an orthodontic case, do you also do a T-scan with that?
That should be done. I agree. I agree. In fact, not only in orthodontics, post your full mouth implant crowns, post your full mouth restorations, T-scan or a similar scan is a must, so that you can establish the bite to the muscles. So yeah, that point even I'll agree. Interestingly, I had a patient which had multiple teeth missing, and he has a bruxism, and he had TMJ pain. So in these kind of cases, our preference is to not just put an implant and give a crown where it is missing teeth, which I'll tell a lot of youngsters. We would like to restore the complete occlusion. How about you?
Can you frame the question again?
So there's a case wherein there is a bruxism pattern, of course, and there are multiple teeth that are missing, and the patient is come only to restore the missing teeth. So ideally, in those kind of cases, you need to actually establish the complete occlusion.
Yeah.
So how would you take up a case?
See, first of all, if you have identified, again, taking the detailed history is of prime importance here. Now, as I told you, there is a lot of comorbidities and systemic conditions which come into play for most majority of the cases, especially when they are secondary bruxism cases. So once you have identified and you find out the cause and you're able to treat that, then of course you can proceed. But yes, in cases of bruxism, even when we give implants, we have to give a protective splint to protect our dentition. That has to be done, because otherwise what happens is because of the sustained clench or probably night sleep related bruxism, encapsulation of implants can happen instead of osseointegration. So we have to protect that.
So the take is, don't just look at the extraction sites and start placing implant. think of occlusion, think of the muscles around it, so that whatever you're delivering is actually helping the patient improve his lifestyle, then just a compromised treatment.
I would say we should not be just, we should not consider ourselves just as dentists, but we are physicians of stomatogenetic system, and the take-home message for everyone would be to take a detailed history. And once we identify, we are not only helping the patients to restore their dentitions, but in general, general health as well.
Correct.
So that is really beneficial for everyone, I guess.